We'll get started and talk a little bit about the general things that we already covered last time. But I think it's important that I share some resources that many of you could use, since many of you have internet connectivity. So let me first share one general resource that I found exceedingly helpful, and I briefly put it on earlier, but let me see if I can bring it back up. And it's a resource that I found very helpful for me to follow along the disease, COVID-19. And it's put together by the Massachusetts General Hospital. And let me bring it up right now so that you can see it. Let's see here. Yeah, this is the resource. It's, and I assume everybody can see the screen here. It's the Massachusetts General Hospital Physicians Answer Questions about COVID. This is by Dr. Paul Bidinger and Rochelle Walensky. The two of them have taken time to put together this nice video. It gives answers to many of the common questions that come up. What is COVID? Where did it start? How did it come about? What is social distancing? How does social distancing prevent disease spread, etc.? So it's about 10 minutes. It's not very long. And there's also a nice transcript where you can read it. So if you really don't have video and you don't have ability to look at the video, or if your internet speed is too low for you to do any of those things, you can just simply read what are the different things that's in there. It also gives you some ideas about if you had an emergency travel, is it okay to travel? Is the airplane a safe way to travel if you have to emergency travel? And when will the pandemic end? What is the historical information that we have about pandemics? And then a few concluding remarks. So I think it's very nicely put together. I thought it's a great resource and I enjoyed watching it. It's accurate, it doesn't hype anything, and it's to the point. So anyone who wants to watch that, this is material that we already covered. Most of what is said in this, we covered in the last session that we had. But for those who wanna just sort of go over there and watch it, that'd be a good one to watch. There's also this great resource. It's a free resource. It's by Coursera. Coursera is the largest online online teaching platform in the world. It's free. There's no cost to it. And it has this session called Science Matters. Let's talk about COVID. And it's from Imperial College London. They are the pioneers in the field. They are the ones that bring in a lot of information that many healthcare scientists are using. It's a little technical, but I think it's worthwhile if you really want to explore. You have nothing better to do. This is a good time to read. It's like a course. And so, for example, it starts with introduction and it talks about key concepts. And there are several videos. I'm taking the course myself. So I would recommend that those of you who have time and want to use the time productively, you can actually run the course and see whether you learn something more than, and it covers a lot of epidemiology, but it's taught in a very, how should I say, down to earth form. So here's an example of how this video plays.
Let's talk about COVID-19. I'm here with Professor Helen Ward and Dr. Katerina Houck, and my name is Oliver Geffen, and I will be the teaching fellow on this course. So Helen, there is already a huge amount of information in the public domain. What are we contributing to this?
Well, what we're hoping to do with this course is to equip you with the tools to understand the scientific principles underpinning the different aspects of response to grief.
Okay, anyway, so I won't belabor the point. So that's a great resource as well if you want to use that to educate yourself on what's scientifically good.
I'm muted, sir.
Does this live stream come on at the time, or?
Yes.
Okay, so I should be okay then, I guess.
So Heidi, can you mute yourself because we can hear
I thought
everything.
I had myself muted. Sorry.
Okay. All right. So, okay. So that's sort of the introduction things. Let me see if Dr. Nazar is here yet. I guess not here yet. But until he comes, I want to just give you some quick updates on where we are and where things are so far. So, there's Nazar. Okay. Hi, Nazar. Hello.
Can you see me?
Yes, we can see you. We can hear you. Thank you very much. Thank you for coming. So let me quickly introduce Dr. Nazar here, who is our guest today. Dr. Abdul Nazar is my medical school classmate, but he's currently a senior consultant in East London Hospital, which is in London, UK. And he has been caring for a number of COVID-19 patients in the ICU. Now, again, just to put this in perspective for everybody who's listening, not everybody will end up in ICU, and not everybody will need the care of specialists like Dr. Nazar, and not everybody will die from the disease. It's a very small minority of people who will eventually get to the ICU and who will get this type of treatment. Whereas majority of patients will have asymptomatic illnesses, vast majority of patients will not even need to seek medical care. There will be a small number of patients who would have illness that can be treated in their homes. And in this case, all you need to do is isolate yourself during that time period. And then a small number will need to have medical care in a hospital where you'll need to go and get treated for pneumonia. But then there are a very small number, and based on what we know now, the case fatality rate, the number of people who actually die from the disease, is estimated to be about 1%. Now that may be an overestimate because we're not testing enough people around the world. So the way we calculate case fatality rate is number of people dead over number of people who are infected. So that's how the numbers generated. So based on current numbers, it's about 1%. So a small percent, probably 3 to 5% people will end up in the care of people like Dr. Nazar. So Dr. Nazar, as I mentioned, is a critical care specialist and an anesthesiologist. He has been in the forefront of treating people with COVID, and East London Hospital is a relatively busy hospital in one of the poorer parts of London, and so they see a lot of morbidity. So with no further ado, here's Dr. Nazar. Hey, Nazar, welcome to our
Thank you for inviting me for this meeting. I really enjoy this. I work in East London Whips Cross Hospital, which is part of a big trust. We look after quite a lot of patients on the East London side. It's called Barts Health NHS Trust. We got 5 hospitals, and I work mainly in Whips Cross side, but we cross cover. Thank you very much.
Great to have you. So let's start off with a few of the questions that our viewers will have. So first off, of the sick people that you've taken care of, many of them have a very dramatic course from what I've heard from you and from others. is that when they come down, they typically come down with classic symptoms of pneumonia, viral pneumonia. So there are shortness of breath and fever is what brings them into the hospital. What things that you do in the hospital triggers you to think that maybe these people have a much more serious illness like COVID-19? Is there things that you can gather from the information that you get that makes you think that, hey, maybe this is a more serious illness?
So basically what's happening now is on the front door, what we see is patients with the background history of diabetic hypertension or ischemic heart disease. They are, hello, can you hear me?
Yes, we can hear you. Yeah, keep talking. I just put up your slide there just to help you.
Yeah, they are coming with 1 week history of fever, cough, severe body pain. Then another thing with the diabetic patients, they are coming with the diabetic ketoacidosis also. So the presenting complaint may be some sort of diabetic ketoacidosis, because I think 1 week they're not eating and drinking at home properly. Okay. Along with that, we get asthmatic patients also. Mm-hmm. So when they get to the stage of can't breathe in normal air, the oxygen concentration starts coming down, and the cough is continuously coughing, then they end up in the A&E. We go and see them. Initial X-ray itself will show the patchy changes from the periphery of the X-ray, which is very diagnostic of COVID pneumonia. So that's acute respiratory distress syndrome signs, early signs in the X-ray itself.
Okay, so let me repeat what you just said, just to make sure that we understand, just for the audience here. So what you're saying is that people with other illnesses like diabetes and asthma are typically the ones that are getting very sick very quickly. And when they come to your hospital, to a unit where they need the care in an ICU, an X-ray already gives you some clues, and the X-ray usually shows patchy pneumonia on the edges of the lungs, which is a first indication that maybe they have COVID-19. Is that what you're saying?
That's right, yeah. Okay. So then when you see the blood results, you typically will see that lymphocytes has gone down. Okay. So they will have lymphopenia, which is diagnostic of, and the D dimer may be very high.
Okay, so I'm sharing your slide here, so just so that people who can see these. So this is the test that Dr. Nazar is referring to, where lymphopenia basically stands for lymphocytes being low. It's seen in 80% of the patient. And then D dimer is another clotting factor test that frequently done in hospitals. So please continue, Nazar.
Yeah, so when you see these three together, patient is unwell, X-ray changes, and lymphopenia, then you see within 5 hours, they really deteriorate. They need additional oxygen in the form of intubating them and artificial ventilation after paralysis. That's the way they present.
Gotcha. So, very nice, very nice. So, once they come in and then you have to intubate them, you're basically putting an endotracheal tube and you're giving extra oxygen, connecting them to a ventilator, etc. One of the difficult things, and many people may have already heard about this from the news media, is the idea of proning the patient. So the idea is to change them from laying on their backs to laying on their stomach. And this is done in the ICU setting to treat what is called acute respiratory distress syndrome, or ARDS. So again, Nazar, would you go over how you do this and how manpower dependent this is to do such a procedure?
This is a highly skilled thing in the intensive care unit. Basically, we need to turn these sort of patients without any damage to the patient. At the same time, these respiratory secretions are very infective. So we should turn the patients without disconnecting from the closed oxygen pump, oxygen supply, and the ventilator. So it's about 5 people. Definitely we need 5 people to turn a patient down. And we keep it like about 16 hours like that. So when you roll the patient, you need all the protections for pressure areas, plus there should not be any disconnection of the tube. So it's a very, it's easy once you had the experience and the skill for doing that regularly in intensive care unit. All the nurses are trained for that. So current situation is very difficult because our intensive cares are fully packed, and we have to one nurse may be looking after 2 patients. So we time all these things to do that properly so that every patient gets the turning. If they are on a high percentage of oxygen, then they definitely need turning. That will improve them.
Okay. So the point here, I think, Nazar, I think the audience need to understand is why this is very manpower dependent, number one. So you need healthcare workers to be there to do this procedure where you have to flip the patient from laying on their back to their stomach while still connected to the ICU, all the intensive care equipment. That's the first part. And the second part is obviously when you're doing it, everybody needs to be wearing personal protective equipment, and that means the whole 9 yards. And we're just not wearing a mask. You're wearing every kind of protection that you can possibly get, because this is a very infective patient, and any little chance that the infection would pass on to the staff who are doing it is going to put them at risk. So this is why there's so much need for PPE. Personal protective equipment, number one. It's also the reason why this is scary when large number of patients end up in ICU. The manpower demand, the PPE demand, the ventilator demand, all those things are giving some nightmares to the hospital administrators and to the government officials. And this underlies why we don't want this to happen all at the same time, and why we want to flatten the curve. We went over flattening the curve before, because if we had a large number of these patients coming to our hospitals at the same time, we would simply overwhelm all hospitals, because we wouldn't have enough people to care and do all the things that we're doing. And this will cause massive mortality because our hospitals won't be able to take care. But people like Nazar, they are there to help us, and critical care providers are there all over the world to help us. But we can't overwhelm the system. We need to do it in small aliquots. So if you get them spread out over time, over several months, then the hospitals can take care of them. So on that note, Nazar, can you tell us what is the expected course of most patients that you have with COVID that you admit to the hospital? How long do they expect people with this illness to stay in ventilator-dependent state? And in your experience, I know it's early days, you're just starting to see these people. How long does it take before you can take them off the ventilator?
So we've liberated few patients from the ventilator, which took 10 to 14 days. So they need aggressive critical care treatment for 10 to 14 days. Then after that, they goes into the step down wards. So I'm thinking it's about at least 1 month in the hospital altogether. So that's the pathway it looks like, because when someone had 14 days spent in the critical care, they will have some disuse, atrophy of the muscles and nerves and all these things. So to recover the full strength and they go back to independence will take nearly 1 month. So we are thinking, when somebody is critically ill with the coronavirus, you're thinking about 1 month in the hospital.
Gotcha.
Out of that, 2 weeks will be in the intensive care unit.
Right. So in your profession, and you've been in this profession for such a long time, you have been assessing patients for major cardiac surgery, major surgery, which involves opening the chest and working on the lungs and within the heart, etc. So you always do risk assessment. You are finding out how well is this patient going to do after surgery. Yeah, this is part of your job. So given that, if you think about it and say, okay, I do this all the time and I look at risks, and I'm sure you've seen very risky patients with multiple comorbidities, with lots of other illnesses, and then you decide, oh, we're going to operate or not operate. Are they going to withstand anesthesia? Are they going to go on the ventilator, come out after this? Compared to that, how does the COVID patient compare to that type of risk assessment? Is it a completely different risk? Of course, the infective risk is there, but besides that, is there a much more higher risk or uncertainty about these patients?
So Department of Health, and we follow the NICE guidelines, National Institute of Health, and so they have given us some guidelines of considering them. One is the frailty score. So if the frailty score is 5 and above, they will do very badly in the intensive care unit, along with some other comorbidities. So we got some scores like SOFA score and Apache, all these things will give us a rough estimate how much and how they're going to do on the ventilator and all. At this time, we are very, very specific about the assessment of comorbidities.
So compared to assessing patients who are going for cardiothoracic surgery, for example, where you probably would do a similar assessment, although you don't use these scores, right? So just to give the audience a rough idea, the listeners here, a rough idea, how well does it compare? How well does it not compare?
So in the cardiac surgery, most of the surgeries are elective cases. You got enough time to optimize and assess properly. Here, we don't have that much time.
Right.
They come in the front door, they deteriorate within 6 hours. So when we have been called for help, we get something like half an hour to do everything.
Right.
It's not easy. It's not
Right. So I think that's the point again for the audience, the listeners here, is to understand that compared to other health risks, this is a very urgent matter, and there's not enough time to think and optimize patients' health care. So you remaining in your best health care before you hit the hospital is very important. So the more healthy you are, the better outcomes you have. And that's true about any ICU anyway. But even in this situation, proper hydration, if you have diabetes, good diabetes control. If you have hypertension, good hypertension control. Being compliant with your medicines, taking your medicines. If you have Parkinson's disease, taking your Parkinson's medicines exactly like you're supposed to. And doing all the things that you can do to optimize your healthcare as best as you can, and staying healthy before this thing hits you is important, because as Nazar was saying, if you're unhealthy to begin with, then your outcome in the ICU is going to be poor. Is that sort of a good summary of how you say that, Nazar?
That's true. Yeah, that's true. Yeah.
Good. Okay.
So yeah, it's very important to control all these things and look after yourself at home, even if you are on locked in.
Yes.
Make sure all these things are properly followed.
Right.
Yeah.
And then we'll stop with this last question for you, just to sort of give you a chance to do what you need to do. I know it's later in the afternoon in London, and it's very gracious of you to come on and spend some time with us.
It's a pleasure. It's a pleasure.
So let me ask you this one final question. This is about visitation and, and how isolated. So we've heard about stories, and many of you who are watching the news media have watched this. Many grandparents, sick people in Italy, they die by themselves in the hospital with no visitation. Nobody is able to visit them. They can't see their children, their grandchildren. because they are in isolation and they are very infective. And so they are in isolation when this happens. Having said that, it's important to be in isolation because you are at your infective maximum when you are in the ICU. And of course, people like Nazar and the nursing staff that work with them, they will use all kinds of different ways to communicate with you, whether it's through using FaceTime or whether it's phone or whether it's whatever, to help you keep communicating. I've heard from many of my patients how scared they are about dying by themselves in the ICU, but I think it's a give and take. You know, you have to make sure that social distancing has to be maintained and no visitation is allowed. Here in Penn State, for example, we have no visitors in the hospital at all. We're trying to reduce as much as possible. And I'm 100% sure this is true in the ICU in London as well. So again, Nazar, your thoughts on how this plays out, because many of our patients have these concerns. Yeah.
So before all this happened in intensive care unit, we used to allow all the terminally ill patients, relatives to come and see them 24/7. If somebody is on the verge of on the palliative care pathway, we allow them to come and see 2 persons at one time on the bedside. So we were very liberal in that, so that they can say goodbye to the passing one. Now what's happening is we update all the critically ill patients' family through the phone every day. The doctors talk to them every day, once at a time. They're not supposed to come to the hospital. And if they are dying, then we allow the immediate next of kin just in the PPE and tell them all the risks involved and tell them that patient is dying on the ventilator. Probably he may not be seeing or listen, he can't hear anything. So we tell them the risks involved for him, for the next of kin coming and all. So most of the next of kins are staying at home. That's what they are doing. Yeah.
Right.
They are very understanding. I know it's very difficult for them, but they are very understanding.
Great. I know your time is valuable, so let's stop my questioning here and let me open up, some of you, if you can open the people's audio to ask questions. If people have 1 or 2 questions for Nazar, anybody who has a question, please unmute yourself and you can ask a question. Unmute yourself. Yeah, anybody wants to ask a question for Nazar, please unmute and ask the question. You can unmute all of you for now, it's fine. Janus, you had a question? Oh, Heidi, yes, go ahead, Heidi. Heidi, we can't hear you. You're muted. Can you unmute yourself? Okay, did you have a question?
I didn't have a question.
You didn't have a question. Okay, anybody else have a question for Nazar? If not, I'm going to let him go and we can continue our session here. Thank you again, Nazar. I appreciate it. And good talking to you.
Thank you.
All right, have a good one. And keep doing your hard work that you're doing. Yeah, see you.
Thank you. Bye.
Bye. So at this point, I'm opening up to any questions that anybody might have. I see Janus has his mic unmuted, but Janus, you have a question? I guess not. So anyone else has questions that people have about anything? I'm happy to answer. We went over last session, we went over a lot of very interesting things, and especially the risks to Parkinson patients. We went over what the risks are, and I will brief. let's, Janus, you need to unmute you if you don't have a question, because we hear the, all right, great. So I'm going to briefly go over what we went last time. I will take about 5 minutes to do that, but I'm going to also ask some of you to share on the screen where you can go back to listen to it if you want to listen to what we went over last time. So first off, Parkinson's disease itself, or having any other neurological illness itself, except for immune compromised illnesses, and we'll talk about that in a minute, does not put you at any higher risk for COVID-19. So Parkinson's is not, just having Parkinson's disease is not a risk factor for you to develop COVID-19. Second, and very important one, is that if you are immunocompromised, and immunocompromised can be obvious, like for example, if you have breast cancer and you're being treated with chemotherapy, then obviously you are at risk for it. And the second thing is, of course, sorry, I don't know why my screen is not showing up, but anyway, you all can still see me, I assume. So yeah, okay. So the second thing is, if you are immunocompromised in other ways, so example, you have diabetes that's not very well controlled, if you have other illnesses that is not well controlled, hypertension, etc., then you may have some immune compromise, or you'll be at risk, as Dr. Nazar was saying earlier. So it's important that those things are kept under control. Now, the other way in which you can be immune compromised is if you're taking medications that suppress your immune system. Examples are steroids. So if you're taking steroid medication for example, multiple sclerosis, or if you're on medications for multiple sclerosis, then of course you're at risk for getting this infection. So those are important things to keep in mind, that you are at risk if you are immunocompromised. Then the third thing we went over is that if you have Parkinson's and you are at risk for worsening of Parkinson's whenever you get an infection, whether it's urinary tract infection or pneumonia, your Parkinson's symptoms are likely to get worse if you get ill. And many of you already know that. If you become sick, then your Parkinson's symptoms become worse. For example, if you have a urinary tract infection, you may have more tremor. If you have upper respiratory infection or pneumonia, then you'll have more dyskinesia. So these are well known. So your symptoms can get worse temporarily while you have an infection. And that's a fact even in regular life, even without COVID. So if you get COVID, yes, your Parkinson's is going to get worse a little bit. So that's important to point that we went over. Making sure you're hydrating yourself well and making sure that you're having proper bowel movements, etc., is important. So maintaining that lifestyle and keeping your diet good, eating good, and doing activities like you normally do is important. Now, since many of you have been asked to stay at home, and you know there are more and more counties coming in by the governor's order in central Pennsylvania, it's important that you do a lot of activities at home to keep yourself fit and be normal. I'm going to ask Samyu Ravi to go over some of the resources that we have put together for you, and you're welcome to use any of those resources. Last but not the least, I'm available all the time. If you want to reach out to me via Samyu or through my nurse, Cindy Adrasdo, feel free to reach out to me. The APDA, American Parkinson's Disease Information Referral Center, is available. So if you guys want to reach out through that as well, and those resources are again available. And at the end of this visit, Samyu will shoot out an email with those resources and numbers. So if you want to reach out to us for any of those questions, feel free to ask us. We briefly talked about dextromethorphan, which is a drug in many cold medicines, whether you can take it or not take it, when to take it, and what to monitor. We discussed that in the last session. Again, that is available as well. So I'm going to ask Samyu to come on and share those resources, the exercise resource, the Dance for PD resource, and some of the other resources. I'm going to ask her to to go ahead and share that. Samyu, can you do that?
Yes. Hi, everyone. I hope you're doing well and you're all staying safe and at home. So I'll start off with just the first resource that we were talking about. So from the last session that we had, I sent out an email follow-up after that, and that included a few links. The first one was this website that we have, the Parkinson's First PA website. We're just going to use that right now as our current updates and information website for the Central PA Information Referral Center. So if you go to parkinsonsfirstpa.com, you see home, and then you see the COVID-19 information and updates. If you click on that, it'll take you to this page where I've uploaded the recording from the last Zoom session that we had last week. And it also has a few of the notes that we discussed alongside in the session. So you can just go there and watch and catch up on anything you might have missed from the last time. And feel free to share it with any of your friends and family who this might be helpful to. And then on the same session, we did talk about the Penn State Health On Demand app, which is what Penn State is offering now for COVID screening. So you can either download the app for your iPhone or your Android, or you can go onto the website and you do a televisit or like a virtual screening. You'll meet with a healthcare professional there. You'll do a virtual screening with them, and they'll instruct you whether you should go down to a testing center or not for COVID screening. So the website for that is PennStateHealthOnDemand.com, and the link is in that site, but just so you know how it looks, this is kind of how it is. You go in there, you put your name in, you sign up. It's really easy. And then there will be a banner just specifically for COVID-19. And if you click on it, you'll see a bunch of providers, and then you'll see who's available and then how many people are waiting in line to see them. And then you can just go wait in line, and then you'll be seen by a provider, and you can talk to them about any symptoms you're experiencing. And then another resource is David Leventhal in New York, who started Dance for PD. They're extending their Dance for PD classes for home. And so this is danceforparkinsons.org. So dance is supposed to be very good for Parkinson's disease and the movement problems that we see associated with it. And so it's also fun to do. So they have live online classes daily with the community chat that you can join for Parkinson's disease. So it's specifically tailored for Parkinson's disease. So I'll put all these links again in our email that I do as a follow-up to this. But if you go to danceforparkinsons.org/resources/dance-at-home, you see all of these classes that they have, and you can just join those classes and dance along with them. And lastly, for all of you who are in Pennsylvania, if you go to governor.pa.gov/newsroom, you will go to Governor Tom Wolf's news page, and this has all the updates for everything, but right now with the pandemic going on, a lot of COVID-19 updates, and they come pretty regularly, and any sort of press releases he has or any statements he makes, you can actually watch them live on this website too. So you guys are probably familiar with this, but just in case, this is also a useful link that you can use. And to add on to all of this, we have been having a free Parkinson's disease exercise class here at Penn State Hershey at the fitness center. Since everyone should be staying at home, we don't have in-person classes anymore, but the instructor, Rob Mikesell, has been recording classes, and we just record our first, it's like a 1-hour class, exercise class, and we will make that into a video and send that out to everyone. So you guys can kind of follow that along and work out at home and stay active, because that's very important during these times, because we don't know how long we're going to be staying home. We shouldn't stop, moving and staying active.
Great. Well, thanks, Samyu. And if you stop the screen sharing for a moment, I just want to go back, and I don't know why my screen is not coming on. So let's see. It should come on. I assume you can still see me. Okay. I want to sort of conclude here with a few concluding remarks. The key things, okay, and we don't want to drag this too much, but I think it's a key important message. Despite everything that you may be getting in social media, despite everything that you might be reading on news and everything, the key thing, the most important thing that you can do to help in this situation is hand washing. And hand washing as frequently as possible, and not touching your face, eyes, nose, and mouth with your hands. That's number one, okay? Hand washing, frequent hand washing. Number two, physical social distancing. It's equally important. The first one and second one are equally important. Social distancing of at least 6 feet. These are the two most important things that all of us need to do, okay? The rest of everything else is not important if you don't do these two things. You have to hand wash frequently and avoid touching your face, nose, mouth, or putting your hands in your mouth. This is something we need to avoid as much as possible. If you do that, you accidentally do touch your face or whatever, hand washing and or hand sanitizing is important. And if you touch something before you touch your face, you have to touch your face, then hand washing. Now, of course, you don't have to go overboard about it. So long as you do it and you use soap and wash your hands, that's all you need to do. And any soap is fine. Any ordinary soap, even laundry detergent is fine. This coronavirus is extremely sensitive to soap. 0.5% tween, which is a small amount of soap, is enough to destroy the virus. So soap is very effective, and so is alcohol. 70% alcohol, which is present in many of the common hand sanitizers, and it is enough to take care of this virus. So you will not infect anybody if you use that. The other question that comes up often, and I will stop there, is whether you should wear a mask or not. If you're not able to maintain social distancing, you cannot be further away from a person. Like, for example, in my case, if I have to go examine a patient and I'm going to be very close to them, well, then of course I am going to wear a mask, because in that situation, I can't maintain that social distance, right? But if you are able to maintain social distance, then there is no reason why you need to wear a mask, because the mask doesn't do you any additional protection beyond that. But if you're going to be outside and you can maintain social distance, then maybe appropriate. But in most cases in central Pennsylvania where we live, we should be able to maintain social distancing anywhere we go. We're not a crowded place like New York. We're not a crowded place like any other place. Then last point related to this mask wearing thing is, if you're in the same household and you have a household which also follows all these rules, we already talked about it last time, you can make a partnership. So if you're doing everything and they're doing everything and you and them are working together, you can be in a partnership, and that way now you can interact with that group of people. Now the group needs to be kept small, about 10. And the governor says 10 people or more should not be there. So in your household, let's say you already have 4 people, and then you have a neighboring household or friendly household that we know they are doing everything that you are also following. You can be partners, and that can be an important partnership for caregiving. So if you have elderly folks living at home that require care and you need to be cared for by more than one person, and there's only one person in the household who can care, then you want a partnership with somebody who can come in and provide that kind of care and not put this elderly person at risk. So you can do that. You can create bridging partnerships with people. It could be a child, it could be a brother, it could be a sibling, it could be a neighbor, it could be another Good Samaritan that you have made a partnership with. But so long as you have that partnership already organized, and they are following the exact same rules that you are following, which means you're keeping social distancing, you're hand washing frequently, and you're not going to put anybody at risk. So that would be the thing to do. So long as all of you do these things and follow these things, this would be great for you. Okay, those are all my last comments. Some of you have any comments before we wrap up here? And we can open up for any questions that anybody have regarding any of these things before we go.
No further comments from me, but if anyone has any questions, feel free to unmute on your device and go ahead and ask away.
Okay, looks like there's no one having any questions. So thank you again, everybody, for joining in. We'll do another session next week sometime, and we'll have more updates and more resources for all of you. Thank you again for being there. Appreciate it.
Thank you.
Bye.